I'm Dr. Michael Blumenfield. Today's Shrinkpod program is coming to you from Amelia Island, Florida, where the Academy of Psychosomatic Medicine is holding its 54th annual meeting. Mr. John Blamphin, former Director of Communications of the American Psychiatric Association, will be interviewing outstanding experts in the area of psychosomatic medicine. From the campus of New York Medical College and the Behavioral Health Center at Westchester Medical Center in Valhalla, New York, I'm Dr. Michael Blumenfield, Professor of Psychiatry, and this is Shrinkpod. This podcast will bring to you information, commentary, and interviews with experts on topics in mental health and psychiatry. You can subscribe to receive this podcast on a regular basis, and your comments and suggestions are always welcome. My email address is shrinkpod@aol.com. And now for today's program.
We're talking tonight with Jimmie C. Holland, MD, who is the Wayne E. Chapman Chair in Psychiatric Oncology at the Memorial Sloan Kettering Cancer Center in New York City. She's also a past president of the Academy of Psychiatric Medicine. And more important for her topic tonight and what we're going to be discussing is that she is a member of an Institute on Medicine committee that has just recently issued a very much of a landmark report on psychosocial services for cancer patients and their families, where they're provided in the community. So Dr. Holland, we're glad to have you with us tonight.
Thank you. Delighted to
And
be part of this.
I have just a sort of a general opening type of an observation which leads to a question.
Okay.
And that is, cancer today is more treatable than it has ever been before. Not curable, but treatable. And people with cancer, rather than dying, are living much longer. In fact, as we heard in one session today, perhaps there are 11 million cancer survivors in the country. Yet, some of your colleagues at this meeting are reporting that people with cancer are twice as likely to commit suicide as are people without cancer. So what's wrong with this picture? Why does that situation exist?
Well, I don't think that's a surprising picture at all. The good news is that we used to believe you got cured of cancer or you died, one or the other. Today, cancer's become a chronic disease, just like diabetes. For many people, they live with the disease, breast cancer, prostate, colon cancer. People live a long, long time. However, for some people, they become quite depressed. They feel hopeless. Maybe I'm not going to do well. People who've had anxiety before, depressive symptoms before. And those people are vulnerable, and that is why the Institute of Medicine report is so important today, because it gives us a kind of a path to say that evaluating people, that at least identifying who's vulnerable, has to be part of the cancer treatment. This integral part is the physical exam, okay? So that's the point we're trying to get across.
Why do you think that we're not doing that today? I mean, this is so-called the land of plenty when it comes to healthcare in this country. We're spending more per person than any other country in the world.
Right.
Our technology exceeds any other country in the world, yet we have situations like that. What's wrong with the system?
What's wrong, I think, is old attitudes. We had a lot of stigma against cancer. We couldn't even say the word for a long, long time. Stigma of cancer is diminishing. Stigma of anything mental or psychological, psychiatric, is still stigmatized. And so I think that doctors still are a little embarrassed to ask a patient, are you having trouble? And the patients don't want to bother the doctor. So I call it the don't ask, don't tell policy. That it's safer just to let the visit go by. Visits are very short today, very fast, and most cancer care is in busy outpatient offices and clinics. So what happens is the patient doesn't say anything, the doctor doesn't want to open Pandora's box, and so none of this is ever questioned. So it is not yet it's not seen by doctors as a part of their general visit with a patient. It's got to be.
What can you describe just briefly what some of these psychosocial problems are, or what does psychosocial really mean in the context of this report?
It's a very important point, because psychosocial is a kind of bundling of all the things people are facing. They're facing trying to cope with the illness, trying to cope with the symptoms. What's it done to my job, to my kids' future? All of these, and what's death all about? I mean, that's very frightening to have a diagnosis like cancer, because all of the old attitudes come back. Cancer equals death. It's been true for centuries. In fact, it's not true anymore. It doesn't really register in a lot of people's brains. So I think that this is why we have to somehow or other have a way to quickly assess people, find out who may need some, who is so depressed that they might be at risk, that might not be picked up in a normal visit today.
Is it just depression, or is it some of these other problems?
It's all of I think it's all of them
whole
together.
mix
It's a whole
of it
mix, and
together.
that constitutes a kind of systems approach. When we say psychosocial, it kind of bundles it all into one thing. But that may mean somebody needs help with their transportation, or their kid who's on drugs or whatever, so that might go to mental health or social work. Another problem might go to the clergy. Some people are worried about God's forsaken me. So you have to find out what's the problem.
How do you do that?
Well, there are a number of different rapid screening tools. And there's a network of the major comprehensive cancer centers that's been in place for at least 10 years, maybe longer. We had a panel in that to work out clinical practice guidelines for managing distress. First practice guidelines for, we call it distress because we don't want to use the psych word, because that frightens patients away, frightens the oncologist away. So we came up with guidelines, and we found, while we can recommend several instruments, there is one question you can ask. How distressed have you been in this last week on a scale of 0 to 10? And patients can relate to that. Pain management changed in this country when we began to ask the question, how's your pain, 0 to 10? So we show a little distress thermometer on a piece of paper in the waiting room and a problem list and say, tell us where you are on this scale. And if they say more than 4, then that's a algorithm to ask more questions and to have the nurse or the oncologist to explore. So it's a two-phase, rapid kind of identification.
What kinds of treatments or interventions, or whatever you would call it, would you use once you identify patients who have these kinds of concerns?
Well, it would depend on what the concern was. If it's
For
transportation, I can't get to my radiotherapy treatments, then you have to ask social work to help with that. If it's that you live out in a remote area and you can't get in to see a mental health person and you're very depressed, we have to figure out a way to take the services by telephone.
How about problems with spouse or family?
Families, that could be mental health, could be social work, but you can beam, if you ask the question, what are the problems, then you can beam it to the right place.